if you want to share your screens.
Hello, everyone. Is Mary here? I'll just share the screen now. Okay. Slideshow.
I'm just going to double check, Jenny, whether she's with us at the minute, because I know she was in another meeting, wasn't she? Just
Yeah,
we won't be a moment.
Okay.
Mary's just joining us now, Jenny.
Oh, okay, good. Mary was going to share her screen. I will stop.
Hi, I'm here.
Hi, Mary. We've just introduced your workshop. So do you want to share your screen?
Yeah, can do.
Fantastic, lovely. Thank you, ladies.
Everyone see that?
I can anyway.
Yes. Yeah.
Excellent. So shall I start then? So good afternoon, everyone. Thank you very much for having us here this afternoon. There are two presenters on this session, Dr. Mary Birken, who's sharing her screen, and me. Mary is co-lead at Motion, as you heard earlier, and I'm the project lead at the Royal College of Occupational Therapists. Both Mary and I have been working on the occupational therapy priority setting partnership for just about 2 years now. And over the next 20 minutes or so, we're going to give you some background on this important piece of work. It was a big project for the Royal College, and it's an important one. And shall I hand over to you, Mary? You were going to speak about the second slide.
Yeah, I guess I was just going to give a bit of a background to this. So as Jenny said, I was on the steering group for the James Linda Lyons Prioritisation Partnership, which is really great experience. And I recommend that if you see any James Linda Lyons priority setting partnerships coming up that are of interest, sign up there and put yourself forward. It's a really, really great experience. So I guess the starting point for the top 10 research priorities was the Royal College of Occupational Therapists put together the research and development strategy, and that was launched last year and it's from 2019 until 2024. And that was kind of developed in collaboration with a range of people. And one of the things that came out of that was a strong sense of, well, maybe we should look at research priorities. So I hope you'd all have a look at the document. It's on the RCOT website, and you might have already discussed it with your team. As I say, it came out last year. So they've kind of set 5 strategic aims for the next year, for the next 5 years. And I won't go through them in detail, but just to say they look at research confidence, capability, and capacity within occupational therapy profession. And they look at that one of the strategic aims was about understanding and implementation of existing evidence, about supporting the generation of new knowledge, and also the continued expansion of the evidence base underpinning the practice of occupational therapy and demonstrating its clinical and cost effectiveness. And I think that for me is really important, in that we can all use evidence-based interventions, but actually being able to say it's clinically and cost effective, I think, is important. So it also looks at enhancing the experiences and outcomes of the individuals who are using or accessing occupational therapy services. And I guess that's what drives us all in research, is wanting to improve their experiences and their outcomes, and know that we haven't done any harm to them, that we've supported them to get better. But without the evidence, there is this risk of, oh, am I making things worse? So we all want to enhance the experience and outcome. And finally, they want to look at the impact of research. So when occupational therapists do research, making sure that we promote this research, and we can disseminate it widely, because that gets us on the platform of evidence-based practice. So I'll hand over to Jenny, who will tell you more about the development of the top 10.
Okay. So the first, when the idea first came through that a top 10 needed to be developed, basically that the research priorities for occupational therapy in the UK needed to be identified, RCOT looked at the different options. The first option they considered was to commission some research. And the reason for that is because the previous Building the Evidence-Based publication from 2007, that was some commissioned research, and that previous research was led by Dr. Katrina Bannigan, and so that option was one option that was considered. The next was a Delphi study. So that's a structured approach to gaining consensus amongst a panel of experts, and consensus is usually achieved through a series of questionnaire rounds, during which new information is fed back to panel members on each successive occasion to refine thinking and prioritisation. And that's the approach that was used by the World Federation of Occupational Therapists to identify their research priorities, which were published in 2017. And so that the disadvantage that the college felt against this approach would be the reliance on a panel of experts, which would mean it wasn't as inclusive as RCOT would like it to be. A third option was an NIHR research priority identification workshop. So that was a third possibility, to ask NIHR to take the college and its members through a semi-formal event designed to gather areas of research unknowns, or to identify gaps in the evidence base, to write and refine specific research questions to address these gaps, and then prioritise those questions. So the priority questions would subsequently be considered by NIHR funding programmes and panels, with a view to possible commissioned calls to address questions that make their way through the process. And again, the disadvantage of that was that at a workshop there's a limit to the number of voices that you can hear. The final option that was considered, and that RCOT went with, was to work with the James Lind Alliance in a priority setting partnership. And the advantage of that is that it's a non-profit making organisation, and its infrastructure is funded by the NIHR. So it's part of that research funding infrastructure. And it has its own methodology that it has set out, and it brings together patients in medical subjects. There's about 100 of these priority setting partnerships that have already been completed, and they bring together 3 groups of people basically. So they bring together healthcare professionals, they bring together patients or service users, and also carers. So they're the 3 main groups. And we also had a representative of social care in our priority setting partnership. So, and they have a whole methodology that they go through. It's a high profile approach to research priority setting, and it aims to ensure that researchers and health related grant funding bodies are aware of what matters most to people who access services and the professionals delivering them. So the methodology is flexible and responsive to particular needs and contexts, but it's underpinned by a number of key principles which ensure a robust, transparent, inclusive and auditable approach that is committed to using and contributing to the evidence base. The focus is on giving equal voice to professionals and those who access services, the carers, and that it was felt that resonated very strongly with the mental person-centred philosophy of occupational therapy. And another valuable feature of this methodology is it ensures that active researchers who might be deemed to have a vested interest don't dominate the final prioritisation process. So people who were involved in the final prioritisation process had to have clinical experience if they came from a professional perspective. And so this was agreed as the best way for RCOT to go forward. Mary, can you move the slide for me, please? So the OTPSP, it started in January 2019, and that's when I was appointed as project lead, and my colleague Ruth was appointed as the project coordinator. And we had Catherine Cowan, she was the senior JLA advisor, and she worked with us on the project, and Jo Watson was the strategic lead. And that image there is the steering group. And so we had a launch event on the 4th of March to raise awareness among RCOT members of the work. And then we put together the steering group. So after the launch event, we started to, or perhaps even before, we started to advertise places on the steering group. And we had 31 applications from occupational therapists and 7 applications from people who access services or were carers of those who access services. We went through the applications carefully to ensure representation from occupational therapists, from practitioners, academics and practice-based researchers, educators, service managers, and to make sure we had representation from all 4 UK nations, along with, most importantly, people who access services and their carers. So the first meeting of the steering group was held on the 29th of April, and the full list of members can be found on the PSP webpage, and you can see Mary's in there as well. So there are about 25 people, and about 5 people were service users or people who access occupational therapy services and their carers. So the RCOT is enormously grateful to the people who participated in that process. And then can I have the next slide, please? And so we set up a network of partners of around 90 organisations. I saw the project primarily as a large engagement exercise. We wanted to hear from as many people as possible, and we wanted to hear from as wide an audience as possible. So RCOT has very good communication channels with its members, so primarily with occupational therapists. To hear from a wider audience, we had to build a network of partners. And so you can see on the PowerPoint presentation, we worked with Autistica. We wanted people who have autism and their carers and parents and family to participate in the online surveys. The same with the British Academy, I think it's British Academy of Childhood Disabilities, and carers. So we worked with Carers Northern Ireland, the British Geriatric Society. We worked with around 90 organisations. We prepared media packs for them, and we really wanted to hear from their audiences. Then can I have the next slide, please? The first formal start of the project was a consultation survey. So we opened that on the 5th of August, and it was open until November the 5th. The purpose of this was to ask people what questions did they have about occupational therapy. So people had the opportunity to write 2 questions down on that survey, and it was available in hard copy, it was available online, and it was available in English, Welsh, and we had an easy read version as well for people who would find it difficult to access the main form. We had a good response rate. We had responses from 927 people in total, and if you look at that list there, I have to point out, you will see that those numbers do not add up to 927 responses, and the reason for that is respondents could tick up to 3 boxes. So you could be an occupational therapist, and you could also be accessing occupational therapy services, or you could be a carer. And then if I could have the next slide. This is a further breakdown of who we heard from. So you can, just over half of our responses came from occupational therapists, and that was all credit to occupational therapists, firstly for being interested in the project, and secondly to RCOT's communication channels. And we did quite well. We had 12% of people with experience of accessing occupational therapy responded, 6% were carers, people who were 18 and older, and 12% were carers of people who were under 18. So I was quite happy with that outcome. And then can I have the next slide, please? Then came the really hard work with this. So we got all of these 927 people responded, and each gave us at least 2 questions. And some people gave us more because we ended up with over 2,000 questions. We awarded a contract to Dr. Hannah Spring from York St John University, and she worked as the information specialist on the project. It was her job to go through those 2,000 questions and firstly to condense them into overarching summary questions. So where there was any crossover, she brought them into one question. And her aim really was to keep the essence of the individually submitted questions in each of those summary questions. So it was really very challenging. And from that, she created a shorter list of questions. And then she had to go through the evidence base to identify which questions had already been answered and which questions had not been answered, or which ones were partially answered. And there was a lot, as Mary will recall, there was a lot of consultation with the steering group on this as well, because occupational therapy is such a broad subject. It was constantly refining the questions to bring them down to their essence. And at one stage we had 77 questions, and then we went back to the steering group and we managed to consolidate it down to 66 unanswered summary questions. And you could ask, why did we want to shrink it? But that was the next stage of the project. We wanted it to be a manageable number of questions so that people would read the survey and prioritise those questions. And can I have the next slide, please? So the initial, this was the second survey in the project. It was the initial prioritisation survey. It opened on the 26th of February and closed on the 20th of May. So in this survey, which was also available in English and Welsh, and we had 4 different versions of the English survey to ensure that people didn't just read the first 30 questions, everybody didn't read the same survey and answer the same, pick their top 10 out of the first 30 questions or so, because they couldn't face reading the full 66. So we randomised the questions and the breakdown of groups and things as well. And we asked our respondents to identify the 10 questions from that 66 that they considered to be the most important for research to answer, to help us to create a short list of summary questions to bring to the final workshop. This whole project was like constantly refining things so that we could have a top 10 and a short list of questions that were important to people. And we went out again to occupational therapists through the RCOT communication and marketing channels. And once again, we worked with partners to access services and their carers and those who work alongside occupational therapists as well. So initially the survey was due to close on the 14th of April, but life changed in March with the onset of the global pandemic. And we had initially planned to have a final prioritisation workshop on the 1st of June, but that also had to change and moved to the end of July. And so because of the pandemic, we extended the closing date. We changed it basically from the 14th of April until the 20th of May. It gave us more time to hear from people and for all of us to adjust to the situation. So we were very pleased in the end to have 1,140 responses. 884 of those came from occupational therapists. And then, it was very hard it's very challenging at that time to get responses from people at access services and their carers. Everyone's focus immediately shifted, and organisations that we previously worked with, their focus had to shift on informing and protecting their audiences about COVID, and it was very challenging to get responses. But we did get responses, and we held facilitated discussion groups on Zoom with specific audiences. Our steering group helped where they could, but people were minimising their contact with others, and it just made it very challenging. Can I have the next slide, please? And there you can see in a pie chart, the vast 77% of responses came from occupational therapists, which means there were just 23% of responses from other people. But if I could have the next slide. So this time it was my turn to analyse the data. And so with guidance from Catherine Cowan, so I calculated the rank of each question according to respondents with lived experience of occupational therapy services and those who responded from a professional perspective. And what emerged was a clear difference between the questions prioritised by the two groups. We ended up basically with 9 distinct questions from people with lived experience and 9 distinct questions from people with professional experience. And they were the 18 questions that we took to the final workshop. And that was the decision of the steering group again. And then if I could have the next slide, please, Mary. The final prioritisation workshop, initially it was due to be held on the 1st of June. We had to move it to the 27th of July. Initially it was going to be held at RCOT in a face-to-face situation, and instead it became the first virtual final prioritisation workshop for the JLA. We used Zoom as our platform. We had 20 people down to attend. There were 10 healthcare professionals and 10 people with lived experience. Unfortunately, on the day, one person with lived experience sent their apologies and they were no longer able to attend. So we had 19 people. We had 2 different breakout sessions. So we had the group came together first thing in the morning to find out their purpose and the structure of the day. Then we had a breakout session. Then people got together after lunch. Then we had a second breakout session, and then we had a final brief rounding up session. There were 4 small groups, and we changed the membership. So in the first breakout session, we had 1 set of groups, and in the second breakout session, the membership changed to make sure that there was fresh thinking was coming through, and people had their ideas challenged. We also put in lots of short breaks. It's just something that we felt was necessary. Because it was a day-long event. It went from 10 or 10:30 until about 3 in the afternoon, much like today. It was back in July. It was the first Zoom workshop that I had organised, and I was quite worried that technology would let us down or something on the day. So there are challenges to this format of an event, but the strength of it was, I think, that there were a lot less apologies than there would have been if it had been a face-to-face event. And I also think as well that we had a much wider audience in terms of geography as well. People who previously, I think it would have been challenging to find people from Northern Ireland and Scotland and Wales to attend the event, but we were very successful in making sure that all 4 nations of the UK were represented at that discussion. And then if I could have the next slide, please. Yes, we came up with a top 10 at the end of the day, so the event was successful. And then the last slide from me before I hand over to Mary is just the list of the top 10. Over to you then, Mary. You're on mute.
Okay. Have I lost sharing my screen now?
No, the screen is there, but it's gone from a slideshow.
Oh, okay. That okay?
Yep, that's it.
Great. Okay. So yeah, I'm sure you found it really helpful hearing from Jenny the process of developing this top 10 list. And what I really liked about it was that it was not just occupational therapists, it was people using the service as well. I think that, as Jenny said, that the priorities for both groups were quite different. So I think having them combined in one top 10 is really great. So I guess just to say that, yeah, as Jenny said, the scope of the top 10, it's not condition specific. It doesn't talk about specific conditions. It talks a little bit about different settings. So, for example, it talks about reducing hospital admissions. But overall, I think it's fed. Looking at the top 10, you can tell that it's a range of different types of questions. And I think the important thing is to remember that these, you would hone them down locally to look at your service. So, for example, if you look at number 1, how does occupational therapy make a difference and have impact on everyday lives? Well, in your area, you'd have to look at what that means for on a local level, and then you'd have to think about what you mean, what is the role of the OT. So I guess, yeah, if you look at number 2, it talks about person-centered practice. And number 3 talks about how can occupational therapists work more effectively with family and carers, people who access services. Number 4 talks about what are the long-term benefits of occupational therapy. And I think that's a very important one for any intervention in health service is it worthwhile us giving the intervention if a year later it has the effects have lasted, have people benefited long-term from occupational therapy. Number 5 talks about what are the benefits or impact in primary care settings. So I said the top 10 don't really talk about very detailed settings, but that one does talk about primary care settings. So this could be your GP surgery, other local services like that in primary care. Number 6 is quite interesting because it talks about how can occupational services be inclusive of both mental and physical health. And I know some mental health trusts that have done a lot of work around training up mental health occupational therapists to deliver physical health care needs as well. And number 7 is what is the role of occupational therapy in supporting self-management? Example, helping people with illness to manage their health on a day-to-day basis. And again, I think that's important because there's lots of self-management programs out there that may not be led by occupational therapists. So I think it's important to look at what is the occupational therapy component of that, what can it offer and what does that look like. Number 8 is of personal interest to me because my intervention was about helping people stay out of hospital. So number 8 is what is the role or impact of occupational therapy in reducing hospital admissions. So again, that could be in any sort of setting, but I think it's an important question. Number 9 is how can occupational therapists work most effectively with other professions to improve outcomes for people who access service. So again, I think that's important to think about the whole overall approach, the whole multidisciplinary team. How does occupational therapy fit in with that best? And number 10, what is the cost effectiveness of occupational therapy services? Again, I think that question for me is really, I'm really pleased to see it here because it can, as well as number 4, it fits quite well together in terms of what are the long-term benefits of occupational therapy, but also how much does that cost? If it's a really expensive service, is it worth it? Will people pay for that? And they're the sort of things that NICE guidance look for. So they look for, is the intervention effective? What are the long-term benefits? And then also, well, is it cost effective? Is it, if money is scarce, do we want to put a lot of money into this service? So yes, I think I'm really pleased to see that there. I'll talk a little bit more about sort of the mental health implications, but I just wanted to hand back to Jenny for just to say about where you might find more information.
Okay, yeah, on the RCOT website there's a page dedicated to the Occupational Therapy Priority Setting Partnership. You can find all sorts of information there, from the makeup of the steering group to the methodology that we used and to the outcome. The top 10 is listed on that page as well. And on the James Lind Alliance website, there's more information there. And one of the reasons that the James Lind Alliance was chosen as a partner on this project was because of their commitment to transparency. And if you look on the JLA website, you'll see the data management spreadsheet. And that shows all of the 2,000 questions that were gathered and how they were combined to reach the 66 summary questions. And it also shows the evidence that Hannah worked through, and so she lists references and things as well. There's a lot of information there, and if you go on the JLA website as well, you'll see that there are a number of the 99 or so other priority setting partnerships and the kind of documents that they used as well. So back to you, Mary.
Okay, thanks, Jenny. Yeah, so I guess thinking about now that you've seen the top 10, I guess it's one thing that I'll sort of think about, what are people's initial thoughts about them, reactions to things that you think might be missing. I think also being able to think about how you might apply them to your area of practice, and what might you do to help. Sorry, I've got a cat who sneaked in. She scratched my leg. What might you do to help begin address the priorities? So just go back to them. So as I said, they're overarching research top 10 questions. So they can apply to every area of practice within mental health. So if you think of inpatient, outpatient, forensic services, rehabilitation services, early intervention services, all those services, these questions can apply. I guess the primary care settings you'd have to think about, that mightn't always apply to every setting. But you can see how the questions would apply. And I think it's important to sort of think about if you think about mental health, the sort of forms of how you might move these forward. So one thing is think about locally in your own service, are there questions within this that are really important for your service to support answering? What would be your internal priorities within this? But also we're hoping that I know the next plan for RCOT is to look at how to support people to translate these into maybe more specific mental health, for example, more specific mental health research questions or mental health research priorities. So my understanding is that the specialist section of mental health will be hopefully, I think they're planning to have an event around this, around the top 10, thinking about what next, what do we want to do? Do we want to develop a mental health research strategy based on these top 10? How do we want to translate them into questions within mental health? Do we want to, yes, what are the next steps? So I think the plan is for that I haven't heard about the date, but if you look out on, certainly Motion will be tweeting about it once we know what's happening, and Motion members will definitely be part of that to work together on thinking about how do you translate this into mental health, and within this, what might be our key priorities that we really want to work on, or where we might start. We might want to start in one of these and have a sort of a plan of a strategy of, well, we'll start with, making it up now, but we'll start off with number 4, and then later on we'll work on another question later on. So it's all I think it's a really exciting time to think about what can we do with these, and what sort of strategy we might put together to move forward with them and to answer the questions. Ultimately, that's what we want to do is, the top 10 is there to be answered. So how do we go about answering these questions, and who might support us to do that? So I think that's all I've got to say. So I think if you think about your local practice and think as a team, do you want to discuss them and think what might be important in your areas? Or on the other hand, look at what do you know about these already. So do you have do you have evidence that shows what the impact occupational therapy has on everyday life in your area? What do you know about person-centered practice? So you can think about as a team, what do you know already, and what are the next steps to answer these questions? What's the space for the RCOT mental health specialist section and Motion? The next steps generally, I think Motion Twitter account will show them. So I think that's all I've got to say. But I think if people want to send us questions for us to answer, that's absolutely fine. And I think that's the plan, isn't it, Tori, that people, we won't necessarily answer them now, but we can answer them later. Is that?
Yeah, we've got a couple of questions that we can probably allocate time to answering now, or would you prefer us to email them across to you, Mary and Jenny, and you can answer them later on?
I guess if we have time, we could answer them now.
Yeah.
What do you think, Jenny?
Yeah, I'm happy to answer them now if we can.
Brilliant. Okay, so the first question was from Linda Jones, and it says, looking at the flip side of engaging service users in the research process, what is the picture for service users as consumers of research? How can they be supported to become more informed as service users and research participants by engaging with research that is readily accessible?
Do you want to go, Mary, or shall I?
Yeah, you start and I can join in.
Okay. The service users that we worked with, there were 5 of them. 4 were, one person was already involved with the college and the publications group. 2 of them were one was very active. He was co-chair of the National Co-Production Advisory Group at TLAB, Think Local, Act Personal. So he was very actively involved. And one of the service users was actually a researcher. She already had a PhD. So to get them to, their role on the steering group really was to make sure that the research that came, the priorities that were identified and the research that eventually came from it was actually useful when it came to the practice side of things. So that was for them to make sure that the outcome was something that people who access services could fully engage with. I'm not sure if I'm fully answering it. Do you want to help out or step in, Mary?
Yeah, so I guess that's the whole process of developing the top 10 is a really good example of working together and looking at the top, deciding them to sell together. And I think definitely the next steps, I think, really needs to keep that ethos going. So if you're locally, you're meeting up to look at them, think about, is there a service user group? How would you involve service user researchers? How would you involve local service users to look at this top 10 with you and say, what do you think of these? And then if certainly an IHR would, when you put in an application for them, you need strong PPI involvement. So I think it's really important that, we sort of think about how we engage, how we continue to engage service users with the top 10 and what they think of it, and then in further developing research questions from there. So I would hope that every event that we have would have service user involvement. It's quite hard because often there's not money for people to come to meetings, and so I know there's huge challenges, but I think it's something that we could bring back to RCOT and say we're really committed to moving forward in a co-produced way as much as possible, having co-produced them with James Lind and I, but how can you support us to do that? So I think it is very important. I think it's thinking about how you achieve that. Yeah.
Can I just add 2 of the things that RCOT is doing now? My colleague, Dr. Jill Ward, who is the manager of research and development at RCOT, she oversees the foundation, and so any applications for funding that identify some of the research priorities will be looked upon more favourably. They're going to use those research priorities to set the agenda for the research foundation within RCOT. And another thing that Jill is also doing is that she's working to have processes put in place within RCOT so that so that those values of co-production continue within the organisation. There were lots of lessons learned from working on the project, which will go forward within RCOT as well.
Fantastic, thank you. And then we've got one more question from Ingrid Unsworth. saying, I'm wondering if any data was captured during the consultation period around which areas people worked in, both geographically but also area and focus of work if an occupational therapist.
We did capture demographic data, but we didn't ask people what area of occupational therapy they worked in. We asked about just the very kind of standard demographic questions. So we asked their gender. The vast majority of respondents were female. We asked their age. Most people seem to be of working age. We also asked whereabouts in the United Kingdom they were based. So we wanted to make sure we had a good geographical spread, so that we heard from people in Northern Ireland, Scotland, Wales and England. We asked about ethnicity as well, so we wanted to make sure we had diversity in terms of ethnicity. And with all that data that we gathered, we compared it against the last UK census to make sure that it was truly representative of the UK population. But the one thing we did not ask was if occupational therapists worked in, I don't know, physical health, mental health, rehabilitation. We didn't gather that data, but the rest is all there.
Brilliant, thank you. I think we've got one more question just before we break for lunch. So this is from Mark McKenna. Relating to the last question, do you feel there are specific areas of practice that should be prioritised when thinking about research?
Shall I leave that one to you, Mary? You look like you have thoughts on that one.
Yeah, I think it's really difficult speaking from sort of mental health, occupational therapy background. It's really difficult to think of which area to prioritise because there's not a lot of evidence in so many areas, and it often is the case of when the government says, right, we're doing a big focus on early intervention, that will be the time to make sure that you make sure research happens within that. But in terms of prioritising an area of practice, it's so difficult because there's so many areas of practice that don't have lots of evidence, unfortunately, in mental health. But I would say within your area of practice, thinking of what's the priority next steps for your area of practice, so that because often people can come up with really interesting research questions, but are they important? So I think the top 10 is like, these are important. So I think that's the main thing. It was what are the most important questions, and then you might decide you want to prioritise the area of practice just because the trust is reviewing it, or nationally there's a big change, or there's a big focus on it for whatever reason. So yeah, so hopefully that helps.
Fantastic, thank you. Thank you, Jenny. Thank you, Mary, for that presentation. That was really, really informative. There's been a lot of positive feedback in terms of that, giving people food for thought in their own practice. So thank you so much for that. We're now going to break for lunch. So if we aim to be back here for 1:30, and then we've got a presentation by Charlotte Carpenter from West London NHS Trust, and it's an overview of her research experience and service evaluation in a high secure forensic mental health environment. So if you stay logged on, and we'll be back at 1:30. Lovely. See you then. Thank you.